Hello, Dr. Aurelus and classmates. Welcome to my SOAP Note presentation. My name is Lovella de los Santos, and I'm currently practicing my clinical duty at the East Valley Community Health Center located in Covina, California. Today, I will be presenting a case that I found particularly meaningful and challenging, involving a young patient with a history of asthma. Here is a brief presentation of the case. The patient initial is WD. He is a 5-year-old Caucasian white male who presented with a chief complaint of wheezing and difficulty breathing. This case was particularly meaningful to me as it underscored the critical importance of recognizing and managing asthma triggers, which can vary significantly among patients. In WD's situation, exposure to cold weather was a clear trigger, highlighting the need to help care providers to assess environmental and lifestyle factors contributing to the symptoms. It reinforces the necessity of a comprehensive asthma management plan tailored to individual needs, considering specific triggers, lifestyle, and family history, and emphasize the importance of regular follow-ups and treatments adjustment. And additionally, the case highlighted the vital role of patient and family education in empowering them to manage the condition effectively, preventing future exacerbations and improving quality of life. This experience demonstrated the interconnectedness of medical knowledge, patient education, and environmental awareness in managing chronic conditions like asthma, reinforcing the importance of a holistic approach to patient care. Let's now move on to the presentation of the case. Here is the subjective information. WD is a 5-year-old Caucasian male born on January 1st, 2015 and covered by Blue Shield insurance. He is unmarried as expected by his age. WD was brought to the clinic by his father, and both are considered reliable historians in providing the patient's medical history and current health concerns. For the chief complaint, patient's father states, "My son has been wheezing a lot and seems to be gasping for breath." For history of present illness, WD is a 5-year-old Caucasian male brought in by his father due to a 2-day history of difficulty breathing and wheezing. The father describes the wheezing as persistent and the breathing difficulty as moderate, with the patient experiencing shortness of breath during physical activities like playing. The father reports that the symptoms began after the patient's played outside in cold weather. The patient has been using his albuterol inhaler, which provides temporary relief. The patient has a history of asthma and has been compliant with his daily asthma medications. There is no history of fever, cough, or recent exposure to sick individuals. The patient has no known allergies. According to the father, the patient's asthma symptoms typically occur once a month, with exacerbations happening about twice a year. For his past medical history, the patient was diagnosed with asthma 2 years ago in 2022. He was never had any surgical procedures and was hospitalized for asthma attack in July 2023. The patient has no known allergies. His current medications include a solution of albuterol sulfate 2.5 mg per 3 ml for nebulization, Flowbent HFA 44 microgram per actuation aerosol inhaler, and a Montelukast 4 mg chewable tablet. His immunizations are up to date, including influenza and pneumococcal vaccines. For his social history, the patient lives in an apartment with his parents and younger sister. He attends daycare on weekdays and enjoys a healthy diet and regular exercise. He sleeps for 9 hours per night and occasionally wakes due to asthma symptoms. His hobbies include playing soccer and video games. He practices safety measures such as wearing helmet when biking and good hand hygiene. His father is a social smoker and alcohol drinker, but does not smoke within the household. The mother also denies smoking within the household or using any substance of abuse during her pregnancy. For family history, the patient's mother, age 29, is a known asthmatic. His father, also 29, has no known history of respiratory illnesses. For review of symptoms, the patient reports feeling fatigue but denies fever and chills. He has periodic eye tearing but denies any other EVE symptoms. He denies ear pain, sore throat, and nasal congestion. He reports periodic wheezing and labored breathing but denies pleuritic pain or hemoptysis. He denies any inconsistencies in his skin color, rashes, hives, abnormal pigmentation, or any other lesions on his skin. He also denies any symptoms of allergies. For objective information, vital signs, all vital signs were within normal limits except for a slightly elevated heart rate and respiratory rate. For physical exam, notable findings included mild respiratory distress and bilateral wheezing. The chest x-ray showed hyperinflation and spirometry indicated an obstructive pattern. For the assessment in evaluating patient's condition, several differential diagnoses were considered, including pneumonia, bronchiolitis, and foreign body aspiration. Pneumonia was considered due to the respiratory distress and wheezing, but it was ruled out because the chest x-ray showed no signs of infiltrates or consolidation, and there was no fever or productive cough. Bronchiolitis, common in young children, was unlikely given this age and the absence of typical viral symptoms such as fever and nasal congestion. For foreign body aspiration was also considered due to the wheezing and respiratory distress. However, the gradual onset of symptoms and lack of choking episode made this diagnosis less probable. Clinical guidelines and peer-reviewed articles were instrumental in narrowing down the diagnosis to a moderate acute asthma exacerbation. The critical thinking process involves considering WD's history of asthma, his positive response to albuterol, and the environmental trigger of cold weather, which collectively supported the final diagnosis of a moderate acute asthma exacerbation rather than other conditions. The plan for managing WD's moderate acute asthma exacerbation involved several key components. Diagnostic studies such as pulmonary function tests will be considered to assess the severity of asthma and monitor treatment response. The treatment regimen includes albuterol sulfate nebulization at a dosage of 2.5 mg per 3 ml to be inhaled every 20 minutes for the first hour as needed, then every 4 to 6 hours as required. Then additionally, a short course of oral corticosteroids, specifically prednisolone, at 1 to 2 mg per kilogram per day will be administered once daily to 5 days to reduce airway inflammation. For maintenance therapy, the patient will continue the Flovent HFA or fluticasone propionate at 44 microgram per actuation, inhaled as 2 puffs twice daily with a possible temporary dose increase during the exacerbation period. Montelukast, a leukotriene receptor antagonist, will be continued at 4 mg orally once daily in the evening. Patient education is crucial, focusing on asthma control, trigger identification, and proper inhaler use, along with providing a written asthma action plan. A referral to a pulmonologist is recommended for further evaluation and management. Follow-up is scheduled in 1 week to assess patient's response to the treatment, with instructions for the parents to contact the clinic if symptoms worsens. The comprehensive approach aims to manage the acute exacerbation effectively while ensuring long-term asthma control. So for the evidence-based practice, the treatment plan aligns with the Global Initiative for Asthma or GINA guidelines, which support the use of corticosteroids and increased albuterol during exacerbations. For holistic approach and caring science, in providing holistic care, collaboration with the patient, their family, and the healthcare team is vital for optimal outcomes. In a recent case, I worked with a patient and their family to create a culturally sensitive care plan that respected their values and beliefs. These involve open dialogues to understand their cultural background, dietary preferences, and health practices, which were integrated into the care plan. I also collaborated with dietitians and social workers to address the patient's nutritional and social needs, essential for holistic well-being. Cultural considerations were key. By respecting the patient's cultural beliefs, we built trust and encouraged active participation in their care. Understanding their cultural perspective on health allowed us to tailor interventions that were both effective and culturally acceptable, improving adherence and outcomes. 2 of Jean Watson's caring processes were evident: cultivating a sensitivity to self and others, and developing a helping, trusting human caring relationship. By being sensitive to cultural nuances, I fostered a trusting relationship that facilitated open communication and mutual respect, encouraging active engagement from the patient and their family. And the care provided was holistic, addressing not only physical health, but also emotional, social, and cultural dimensions. By considering the patient as a whole person, the care plan promoted overall well-being and healing, ensuring interventions were clinically effective and personally meaningful. In conclusion, this case was a valuable learning experience that underscored the significance of a holistic approach in managing chronic conditions like asthma. By integrating medical treatment with environmental and emotional considerations, and by fostering a caring and trusting relationship with the family, we can enhance patient outcomes and quality of life. This experience has deepened my understanding of the interconnectedness of various factors in healthcare and reinforced the importance of compassionate, patient-centered care. Thank you so much for your attention. Have a good one.